the sort of English phrase. Essentially, any sign or symptom on a test or that suggests that there's a presence of a disease process that is dangerous. Essentially, anything that can affect mortality and can be treated successfully if you identify it early. So it's a kind of, what are the danger signs to look out for? And in the context of cardiology, there are a whole slew of diagnoses. This is not exactly exhaustive, but I think if you had a sense of how to notice when any of the diagnoses in this list is likely or possible, then you won't go very far wrong with anyone who has a potential cardiovascular problem. And I will go through the majority of these, but depending on time constraints. But during the course, you will cover all of these in some way, shape, or form. So I'm not going to do the talk in this particular order, but to start off with, I'm going to pick out probably one of the most important red flag areas, and that's to do with coronary ischemia, in other words, acute coronary syndromes, which consists of non-STEMI, unstable angina, and ST elevation myocardial infarction. And the red flags from the point of view of the clinician approaching a patient is that to do with symptoms. And chest discomfort is the most frequent manifestation, but not the only manifestation of ischemic chest pain. Importantly, it's not often described as chest pain. So if you ask patients, do you have chest pain? And they say no, that doesn't mean that they're not having some form of coronary ischemia, because patients often describe the chest discomfort as a gripping or tight sensation. They don't really equate that to pain. So you do have to ask a very open question, and you have to clarify. If they say they don't have any pain, do they have any discomfort, or do they have any indigestion or any abnormal sensation in their chest? Atypical symptoms, and by that I mean symptoms that are not clearly related to exertion, or symptoms that are not in the center of the chest, which is typically where ischemic coronary chest pain is classically felt. If it's to the left side or to the right side, that can still be a manifestation of coronary ischemia. It's just less typical than the classic central chest discomfort that you read about in textbooks. And the chest discomfort that's in the center of the chest, the reason it's in the center of the chest is that embryologically, the heart, the conus cordis and the truncus arteriosus, before they envelop and change shape and twist around each other and move to the left side, they actually start in the midline. And so in terms of the kind of pain imprint in the brain, anything that happens in the chest in many patients, the majority of patients, will be felt as a pain in the center of the chest, even though the discomfort is actually originating in most patients on the left side of the chest. Having said that, you can still have left-sided chest discomfort, and it can be a manifestation of coronary ischemia. So it's just to give you a kind of handle on why the majority of patients, and why classically chest discomfort that's ischemic in origin from the coronary arteries is described as coming from the center. And alongside that, any discomfort along the midline going up to the throat and into the neck and even into the teeth and gums, that is also a manifestation of classical ischemic chest discomfort. Be wary of unexplained discomfort. So, but by that I mean, if someone comes to see you in the clinic or in the emergency department and there is no clear explanation for chest discomfort, always think, could this be an atypical manifestation of coronary ischemia? If there is an alternative, the flip side is also true. If there's an alternative explanation, in other words, someone is let's say is well known to have gastroesophageal reflux disease, or the symptoms are clearly related to some trauma to the chest, just to give an extreme example, then even if the chest discomfort is in the middle of the chest, if you have an alternative explanation for it, that is a very good indicator that it's not ischemic chest pain. Reproducibility is often described in textbooks. In other words, if you can touch the chest wall and it reproduces the chest discomfort, that's supposed to be a good indicator of it's not being ischemic chest pain, but that is incorrect. When you have any kind of chest discomfort, including coronary chest discomfort related to ischemic coronary pain, the whole chest will become sensitive. And so if you press on the chest, it's very likely to elicit some form of discomfort, and that can erroneously be ascribed to the discomfort being mechanical or musculoskeletal, when in fact it's not. The same is true if someone's had a heart attack, a myocardial infarction. Often the chest wall becomes much more sensitive because the body is much more aware of sensations coming from the thorax. And therefore, if you try and elicit that simply by pressing, you can either be overzealous and cause discomfort inadvertently. But even if you just apply light discomfort, light pressure, in some patients, they will feel that as discomfort. And you might think, oh, that means it's musculoskeletal, but actually that's incorrect. So don't be fooled by the reproducibility. I think where reproducibility comes into its own is really if there's a history of trauma or potential trauma, and you're trying to elicit some focal area around a rib or muscle group that just to confirm your clinical suspicion from the history that someone's chest discomfort is likely to be musculoskeletal. It's that way around, rather than someone who has unexplained chest discomfort and you press their chest and they go, oh, that hurts. And you go, oh, well, that means it can't be coronary. That's incorrect. The other thing is relationship to position also does not exclude serious disease. So although classically pericarditis, which is a mimic sometimes of an acute coronary syndrome in terms of the ECGs and the type of discomfort in patients with atypical symptoms, the fact that pericarditis tends to be easier or relieved when you sit up and is worse when you lie back doesn't necessarily mean that the patient hasn't had an acute coronary syndrome, because particularly with large territory myocardial infarctions, that patients will often have subsequent pericarditis. So it may be that the pain or discomfort relieved when sitting forward is an indicator of pericarditis. That's true, but you shouldn't forget that pericarditis can sometimes be a subsequent result of a myocardial infarction or a recent one. So don't be fooled into accepting symptoms that are relieved by position as being an indicator that an acute coronary syndrome has not taken place recently. I hope that makes some sense. So moving on to the next red flag area. In fact, before I go on, maybe it's a good idea to ask, are there any questions about the ischemia, ischemic chest pain or not? We can always go back to it, we'll circle back to it at the end. Going on to the next topic, namely syncope. This is quite a common presentation in emergency rooms, and by syncope we mean transient loss of consciousness. That's not related to trauma. So if someone, has a concussion, gets hit in the head and loses consciousness and then wakes up again, that's not a syncope. That's traumatic head injury. So syncope is a cardiovascular cause for a transient loss of consciousness, and it's distinct from epileptic seizure. So one of the most important things, which I haven't put on the list here, is to actually get the diagnosis. In most cases of syncope, the history alone gives you a very strong indicator as to whether an episode of transient loss of consciousness is a syncope or likely to be a syncope or not. On this, and I can go into the differentiation of those two later if people wish, but if you think that someone is likely to have had a syncope, then the red flags for a cardiac syncope, in other words, a syncope, a cardiovascular syncope that's not benign, in other words, not a reflex vasovagal syncope and not a orthostatic mechanism for the syncope, both of which are benign causes of syncope. They are easily rectifiable with physical countermeasures or adjustments to drug therapy, and they do not impact on prognosis, importantly, hence not red flag. If pointers in the history that suggest that you're dealing with a cardiac syncope, so that's a syncope that's related to, for example, a structural problem of the heart, an arrhythmia, or some occlusive problem such as a pulmonary embolism or aortic dissection, etc., etc. For those, the markers of those of that manifestation include things like syncope that occurs on exertion or when sitting down, recurrent episodes, particularly if they're unpredictable. Clearly, if there are sentinel symptoms such as chest discomfort radiating to the shoulder blades at the back, that suggests an aortic dissection, or potentially if there are risk factors for thromboembolic disease, and so on and so forth. But what I've listed here are some very, very broad red flags in the history. So again, if there's no alternative explanation, someone has a syncope, but there isn't any explanation, you cannot, if you cannot explain it by a simple vasovagal or orthostatic mechanism, then that's a red flag for a potential cardiac syncope. Again, anyone having a syncope over the age of 45, that's an arbitrary, the age group, but around the age of 45 and above, then again, think, could this be a cardiac syncope? Anyone obviously who has a known structural heart condition, or anyone who has an abnormal ECG or physical signs, cardiovascular physical signs, and in particular, patients who have a family history of sudden death. And by that, I mean sudden death below the age of 40. Someone who has a history of heart disease age 75 is not the same as someone who has heart disease leading to death at a younger age. So that any of those symptoms or historical features would be red flags towards a cardiac syncope. And of course, in the problem with the challenge with syncope is that by the time you see the patient, they are well because it's transient, and so by the time you see them, there aren't any obvious signs to detect. The counterpoint to this is that if you have a patient and they have a clear prodrome and there are clear contextual environmental factors, warm environment, patient who responds, who has a syncope in the context of pain, or when they see some blood, or when they're in a warm room, or after an emotional outburst of some kind, then that is much more likely to be a benign cause, a reflex cause. If someone has a postural drop on blood pressure, again, that's pointing towards an orthostatic mechanism. If someone has, in other words, a benign cause, if someone has a number of antihypertensive drugs, and the syncope occurs in the standing position, again, likely to be a marker of an orthostatic or benign mechanism. So there are two sides. You need to determine, is this a cardiac syncope, and also whether there are any signs or symptoms that suggest it's a benign cause. So in terms of syncopes to send to the ED, this is in the context of of being in your in a clinic outside of a hospital, anyone who has structural heart disease, anyone who has a pause more than 3 seconds, second degree AV block, that's sometimes called Mobitz type 1 and type 2. So I'd say any of those, whether it's Mobitz 1 or 2, you should send them to the ED. Alternating bundle branch block, QT syndrome prolongation, or even a very short QT interval. Anyone who's had broad complex tachycardia, anyone who's got an ECG that shows pre-excitation. And I think there will be an ECG webinar that's separate to this, and we can go through some of these at that point. Again, syncope that occurs during exertion or in the supine position, the syncope that causes an accident, particularly when the most common manifestation of that is when people lose consciousness when driving a car. A family history of sudden death, with the caveat of the age at which that occurred, and any recently implanted cardiac device, pacemaker or a similar cardiac device, resynchronization device, ICD, etc., implantable cardioverter defibrillator, anything like that, even if the symptoms suggest it might be benign, I think they should still go to the ED for analysis, for evaluation rather. Moving on to the next red flag in the list, pulmonary embolism. I think very simply, if someone comes in with a clinical syndrome, which could be chest pain or chest discomfort, don't forget that particularly with the large central pulmonary emboli, they will lodge in the pulmonary trunk and the main pulmonary arteries, left and right. And that will give you central chest pain or discomfort, as opposed to peripheral smaller emboli, which tend to give you unilateral discomfort related to peripheral infarction of lung tissue. So ironically, the ones that are classically described as pleuritic chest pain are usually the smaller emboli. Of course, you can have both large and small at the same time, but the one that catches people out of those patients who present with central chest discomfort and all the other features of an acute coronary syndrome aren't there, and the troponin is normal, the ECG is normal, and you think, well, all the acute coronary syndrome tests are reassuring, so nothing to worry about here. Just be aware that this is a classic, can be a classic symptom of a central pulmonary embolism. If you think of a diagnosis, if you thought, this could be a pulmonary embolism, then you really need to refer the patient to hospital. And if you're in hospital, you really need to do either a D-dimer test, or if you are clinically very suspicious, if you clinically strongly suspect a pulmonary embolism, you need to do a CTPA, irrespective of the D-dimer. So CTPA being a CT pulmonary angiogram. Pulmonary embolism mimics lots of conditions, and so rather than listing all the potential symptoms and conditions it can mimic, I think the easiest nugget to give you, top tip, is that if you think, could this be pulmonary embolism, you need to do something to exclude it. I've already mentioned about pleuritic chest discomfort. Obviously, acute dyspnea is a common manifestation of PE. As is syncope, and the syncope usually means that there's been a large central pulmonary embolism that has temporarily interrupted blood flow through the right heart, and that is what causes a syncope. That's the mechanism. Don't forget the background pre-test probability is very important. If someone has cancer, if there has been long travel, that's usually defined somewhat arbitrarily as anything more than 4 hours, where you're sort of sitting
Dr. De Palma, can you hear me? We cannot hear you. Something happened to your audio.
Can you hear me now?
Yes, now we can. Yes.
Okay.
There were a few minutes that we have lost you for about 3-4 minutes.
Okay, 3 or 4 minutes. Okay, fine. Sorry about that. So let me just go back to heart failure then. I don't know where we left off, but I was just saying about heart failure that exertional dyspnea is often described in the textbook as a classic symptom, which it is, but it happens quite gradually, and so patients sometimes don't describe breathlessness as a feature of their symptoms, even when asked. But they will often say that they are fatigued and they don't have the same exercise tolerance that they once did. So don't just be aware that just because someone doesn't say that they are breathless doesn't mean that they haven't got heart failure. Also, don't just accept peripheral edema as a cardinal sign of heart failure. It is true that if you have congestive cardiac failure, in other words, left and right-sided heart failure together, left followed by right, you will often, the patient will respond to that by retaining salt and water, and that will lead to peripheral edema because of gravity. Fluid accumulates in the most dependent parts of the body, particularly in non-bedbound patients. But it's not the only cause. And don't forget to feel for an apex beat, listen for a third heart sound, look for a raised jugular venous pressure. These are very useful corroborative signs of heart failure. And nowadays, with the advent of NT-proBNP and BNP, these are biomarkers of cardiac stress, if you like. They have tremendous negative predictive value and very useful, particularly in those who have potentially multiple causes for symptoms. So an example would be someone who has emphysema and they present with worsening, let's say, exertional dyspnea. If you do a natriuretic peptide measurement and you notice that the natriuretic peptide measurement is entirely normal, that's very good. A very good negative predictor of it being due to heart failure. In other words, you can exclude heart failure that way. The other very important thing is it's very unusual. I'd say almost as good as a negative natriuretic peptide. It's very unusual for someone to have heart failure and have completely normal ECG. So those two things are very, and the history and examination are very good ways of excluding the vast majority of patients who have symptoms that might be heart failure, but actually it's not due to heart failure. Where you have marginal cases, a slightly abnormal ECG, borderline natriuretic peptide, or even a raised natriuretic peptide, then the next step would be echocardiography to try and clinch the diagnosis. But don't just, anyone who has breathlessness, just send them for an echo. I think you have to go through a clinical process because a lot of these patients will not have heart failure. And the reason identification of heart failure is important is because there will always be an underlying etiology. And notwithstanding trying to find out what the etiology is in order to treat it and prevent the heart failure getting worse and hopefully reversing it, you need to start patients on guideline-directed medical therapy, which we haven't got time to go through today, but it includes the 4 pillars. This is over and above diuretic therapy. Those 4 pillars would be something to block the sympathetic nervous system, in other words, beta blockers, something to block the renin-angiotensin system, and that would be the ACE inhibitor, an AR2B, or Entresto, which is a combination of sacubitril and valsartan and AR2B, a mineralocorticoid receptor antagonist such as spironolactone or eplerenone, and an SGLT2 inhibitor. Those 4 pillars are very important because they help, in addition to the diuretic, which commonly is furosemide, could be other types of diuretic, of course, but those 4 pillars help not just symptoms but prognosis. So the diagnosis of heart failure is important, and is becoming much more live as we're going into an era where there are lots more survivors from valvular heart disease and acute coronary syndrome because of the good acute treatments that we have available. And so there will be a lot of patients that have heart failure, but you do need to detect it in order to get them on these prognostic and symptomatic symptom relieving medication as soon as possible. Atrial fibrillation. This is one of the commonest arrhythmias that you will encounter, increases with age, and as the demographic of high and middle income countries increases, the risk or the frequency of AF detected also increases. The importance of atrial fibrillation is mainly related to the fact that it's closely associated with the risk of ischemic stroke. And ischemic stroke is a huge morbidity on patients, but also healthcare systems, and of course it leads in many patients to an early death. So there is a premium on detecting atrial fibrillation as early as possible in order to mitigate against those risks with anticoagulation, typically in the form of direct oral anticoagulates, formerly known as NOACs. Now, in terms of the detection or diagnosis, what you need is an irregular pulse, confirmed with an ECG or some kind of electrocardiographic monitoring that shows that there are no discernible P waves. And that is all you need for a diagnosis. So it's something that can be diagnosed at a surgery, in an ED. You don't need sophisticated tests for it. And it's recommended that opportunistic screening is very helpful over the age of 65. So anyone attending for some other condition that's not directly related to the heart should always feel a pulse. I think it's good clinical practice if you're ever encountering a patient clinically to feel a pulse. I think it's a very good, not just opportunistic screening for AF, but also gives you a lot of information about the cardiovascular system, and also is part of the sort of rapport that you form with patients, which is very important and often neglected. In terms of the question that often comes up is in terms of ambulatory ECGs, sometimes described as Holters, after Dr. Holter, who devised it in the 1960s. The length of time that you need on an ambulatory ECG for an irregular rhythm without P waves, for it to be called atrial fibrillation, is 30 seconds. Now that is arbitrary, but it's the entry point for all of the studies since they started recruiting patients in the context of AF, and so that's by convention what we use. It doesn't mean that someone who has 29 seconds of irregular rhythm on a ambulatory ECG without P waves isn't AF. And what I would say, and this is the question that comes up sometimes, if you have someone who does have slightly less than that or less than that, and they have raised or markers suggestive of a raised risk of stroke, and that is the CHA2DS2-VASc score. That's the clinical way that you can determine that quite easily in practice. Then you can treat it as atrial fibrillation. And the key point for this is that the risk of stroke isn't due to the fact that the heart rhythm is irregular. The risk of stroke is related to the fact that you have an atrial myopathy, a diseased left atrium, and AF is just a consequence of that diseased left atrium. And the CHA2DS2-VASc score is really, in a very crude way, giving you a risk score of or how likely the atria or atrium, left atrium in particular, is to be diseased. So you could have a situation where someone has atrial fibrillation, high chance VAS score, you treat them for atrial fibrillation with direct current cardioversion, you convert them to sinus rhythm, and you might think, oh, well, okay, so they're now in sinus rhythm, they don't need to have any anticoagulation to protect them against the ischemic stroke. Well, that is incorrect. They do, because the atrium is still diseased. All you've done is that you've got them out of atrial fibrillation, typically because patients feel better in sinus rhythm generally, and often atrial fibrillation is associated with symptoms. But in terms of the risk of stroke, that's related to the CHADS-VASc score. So please, whenever you have a question on atrial fibrillation, people get sucked into the treatments and the diagnosis, but don't forget the CHADS-VASc score. It's very important. It should be like an automatic red flag that goes up. What's the CHADS-VASc score? Because that will tell you what the risk of future stroke is. And roughly speaking, each point on the CHADS-VASc score is about a 1% cumulative annual risk of stroke. One point that's come up from previous talks is what do you do about paroxysmal atrial fibrillation and atrial high rate episodes? That means atrial fibrillation detected on a device. And the answer is, generally speaking, they're treated the same as atrial fibrillation. Statistically, there is a very slightly reduced risk of ischemic stroke with paroxysmal atrial fibrillation, but it's not of any clinical significance. With atrial high rate episodes, a little bit more complicated. I've oversimplified in this slide, and you won't be asked about it in the exam, but we're not 100% sure, and it's a little bit of a sort of research entity, to be honest. Some practitioners will require quite a few, 20 minutes, 30 minutes even, of atrial high rate episodes detected on a device before they will call it pathological. Others will accept the standard 30 seconds. I think the truth is probably somewhere in between. And the reason is, when you have a cardiac device and wires in the heart, the wires themselves can cause irritation of the atria, but that's not the same as an atrial myopathy. So I think the key concept here, which I think most people don't or often forget, particularly at a more junior level, is that the risk of stroke is related to myopathy of the atria. It's not the AF itself. AF is just simply a marker, a very strong marker of atrial myopathy, and that's why we anticoagulate patients who have AF. But even if you're out of AF, if you've got a high CHADS-VASc score, then the risk of stroke is there. And some practitioners, although it's not in the guidelines, will anticoagulate patients who've got a very high CHADS-VASc score, even if they've always been in sinus rhythm. Now, that's not the advice we give in guidelines. You do have to have an episode of atrial fibrillation to qualify for anticoagulation, but it's just to underline the point that the CHADS-VASc score is critical in your management of AF. Okay, I'm going to just skip this for the time being, because we've described it more or less. And yeah, just one thing about the CHADS-VASc score is that don't forget that the CHADS-VASc score has female gender as one of the points that in the score, and that is a historical feature that is subsequently been shown to be erroneous. In other words, being female doesn't put you at increased risk of ischemic stroke, but because all the statistics were based on the original CHADS-VASc score and it's integrated into the acronym, it's very difficult to take it out. So it's been left in, and the way the workaround for it has been that if your only risk factor on the CHADS-VASc score is being female, then that doesn't qualify for anticoagulation. So if you're female, you need to have 2 points, and if you're to be considered, and if you've got more than 2 points, then it's a mandatory. If you haven't got as long as you don't have contraindications, it's a mandatory indication. If you have, if you're a male and you have 1 point, you should consider it strongly, and if it's 2 points or more, then it's a mandatory indication for anticoagulation. they've got, some places, some parts of the world will still be using warfarin, so that is fine if for health economic reasons, if there is no access to direct oral anticoagulants. But generally speaking, for non-valvular atrial fibrillation, the direct oral anticoagulants are recommended over vitamin K antagonists, of which the most frequent is warfarin, because they are easier to use, there's more compliance, and there's a lower risk of intracranial hemorrhage complications. The only exception to that is if you have mechanical heart valves, or if you have moderate or severe mitral stenosis. Under those conditions, then it's and if you have those conditions and you have atrial fibrillation, then it's vitamin K antagonist, typically warfarin. Of course, if you have a mechanical heart valve, you will be on warfarin anyway to protect the mechanical heart valve itself. Okay, I think, just some other points in terms of the sort of general topic of AF and red flags. If someone has had a history of falls, because don't forget atrial fibrillation increases with age, then that has to be a very high risk of falls and recurrent falls in order for you to in order for the benefits of anticoagulation to be outweighed by the risk of falling and traumatic injury leading to bleeding complications. Okay, I'm just going to go to ECGs as we're running out of time. There will be a separate webinar on this, but what do we mean by an abnormal ECG? Because of course, the ECGs that have abnormalities don't always indicate that there is a life-threatening problem, a red flag, in other words. So any ST elevation, particularly if it's new and accompanied by symptoms, is a red flag. Now, of course, if someone hasn't got any symptoms and they're clinically very well and they have fixed global ST elevation and they're young, it's very likely to be a normal variant. So we're talking about patients who have symptoms. Always correlate the symptoms with the ECG. Similarly with ST depression, fixed ST depression can sometimes occur and be a normal variant, particularly if it's very, very mild, i.e. less than a millimeter in females. But if it's accompanied by chest discomfort or symptoms suggestive of a acute cardiac condition, then you have to take that as potentially abnormal. Long QT interval. Don't forget the QT interval has to be corrected for heart rates. The computer algorithms on ECGs tend to overdiagnose it. But nevertheless, again, if you have someone who presents with a syncope or pre-syncopal symptoms, and you have an ECG that suggests there's a long corrected QT interval, then that is a red flag. Complete heart block, again, that is a red flag always, even if the patient doesn't have symptoms, because it indicates a poor prognosis. But nearly always they will have symptoms, typically in the form of a syncope, sometimes with heart failure, but typically syncope or pre-syncopal episodes. And again, I'll go through this in an ECG webinar, or someone else will do this. But what you're looking for is a disconnection between the P wave activity and the ventricular escape rhythm. It's often described as AV dissociation, atrioventricular dissociation, or P waves marching through the QRS complexes. And a very easy way is just to look at the rhythm strip on an ECG and look at the P waves, which will be going at a much faster rate than the QRS complexes. And if there's no obvious relationship between the P waves and the QRS complexes, then you're dealing with most likely complete heart block. There are exceptions, but most likely complete heart block. Similarly, a question that sometimes comes up is if you have atrial fibrillation, in other words, no discernible P waves anyway, how can you tell if someone has complete heart block? And the answer is, if someone with atrial fibrillation presents with symptoms, or even without symptoms, but typically it will be with symptoms, and they have a regular QRS complex rhythm, then that is very likely to be complete heart block. So AF, known AF, with regular QRS complexes equals complete heart block. Atrial fibrillation, we've spoken about that at reasonable length, is something that you need to be able to detect because of the potential risks and the fact that mitigating those risks is actually quite easy nowadays. And ventricular tachycardia, which essentially is manifests in the vast majority of people as broad complex tachycardia, is clearly an abnormal ECG. And sometimes questions get asked about differentiating between supraventricular tachycardia with a bundle branch block pattern or with aberrant conduction and ventricular tachycardia. And I will go into that in a little bit more detail during the ECG webinar. However, the simple rule of thumb at the level of the primary care or sort of the coal face of emergency room is that if someone comes in with a broad complex tachycardia, assume that it is ventricular tachycardia until proven otherwise, and that's the safest course of action. A little bit about the QT interval, which sometimes students are exercised about. The reason we get interested in the QT interval is that it's associated and causal, has a causal link with a form of ventricular tachycardia called torsade de pointe. It's a French name meaning twisting around the points, and there is congenital long QT syndrome, which nearly always gets picked up quite early in life and gets diagnosed quite easily before they even get to adult healthcare practitioners. But it's the acquired long QT syndrome that often exercises us. And that can either be caused by metabolic disturbances, and typically there is an underlying diagnosis that leads to hypokalemia or hypomagnesemia, hypocalcemia, and so on. But often drugs that are used for relatively benign conditions such as hay fever can sometimes prolong the QT interval in susceptible subjects. The problem is how do you know when a QT interval is abnormal? And when I'm talking about the QT interval, I'm talking about the corrected QT interval. Now, a very simple rule of thumb is that if you have a QTc interval that's more than 500 milliseconds or more, whether or not you have a syncope or pre-syncopal event, is abnormal and needs to be explained. And if it's due to a drug, then the drug needs to be withdrawn to see if the QT interval improves. If you have a QTc between 460 milliseconds and you have a syncope, that's also definitely abnormal. The problem sometimes comes with people who have marginally elevated QTCs and have no symptoms at all. And it is possible that the prolongation is just part of a normal variant in that person, or it could be caused by some drug that they're taking. So under the circumstances, you can either adjust the drug to see what the QT interval does, or you can do an ambulatory ECG to measure the QT interval over a 24-hour period, which is much more accurate than a 12-lead ECG, or seek specialist help. Usually it's all of the above. But just be aware that the real red flag here is the 500 milliseconds, or if you have a QTc interval that's prolonged in the context of a syncopal event. The other sort of feature of the history that would raise concern would be if there was a family history of sudden death at an early age. And obviously, if you have an obvious antiarrhythmic drug that's been used for something else, common examples would be flecainide, amiodarone, stotolol. If you're unsure about whether drugs can be associated or are associated with a prolonged QT interval, there is a website called Credible Meds, which has been assiduous in collecting all this information around the world, and it's free to healthcare practitioners, and it's something that you should have as an app on your mobile device or on your computer if you are able to. Okay, that's just a simple description of what a QT interval is, and this is what looks like a very busy slide, but just to explain that the normal range for QT intervals and the long QT syndrome overlaps, and it's at the overlap that it can be difficult to know what the whether a QT interval that's prolonged is abnormal, pathological, or just normal variant, which is why I described it as I have. And that's just an example of what can happen with Torsades. Okay, a little bit about ST elevation in the closing slides. This is an example of benign ST elevation where you have a raised J point with a concave pattern to the ST elevation. And also, if you notice the concavity is quite global, and this is an example of someone having pericarditis. And although pericarditis itself does need treatment, it's not in the vast majority of patients a dangerous condition. It's not acute coronary syndrome, and it's important that you recognize that some patients will have a similar looking ECG and it can be a normal variant. So it all depends on the symptoms. So always, whenever you're looking at an ECG that might be abnormal, always reflect on the symptoms associated with that ECG. This is another type of ECG that, if you were to find it, is a potential red flag. And this is a Brugada pattern. And this is due to, in most people who have it, a sodium channel abnormality, which I don't need to go into now, but it puts you at potential risk of sudden arrhythmic cardiac death. There are several types, and anyone having any of these types should be referred to a specialist cardiologist. In fact, it's only type 2 and type 3 that are associated strongly with sudden arrhythmic cardiac death, and type 1 is a mixed bag, and it depends on provocation testing. But anyway, you don't need to learn about that. What you do need to know is that if you have this humped back appearance, particularly in the right ventricular leads, which are V1 and V2, then always, particularly in the context of syncope and family history of sudden death, then they need to be referred. But even if they don't have that, I think this abnormality alone needs further investigation. Okay, I think this is going to be probably the last, one of the last red flags. I don't know if we have enough time, but for cardiovascular issues to do with pregnancy, any pulmonary hypertension is a red flag. Anyone who has severe left ventricular dysfunction is a red flag. If you've had previous peripartum cardiomyopathy with any residual left ventricular impairment, that's a red flag. If you recover completely from a peripartum cardiomyopathy, it's, I would say, an orange flag, where you do still need to have specialist input, but under close supervision, patients can still have a successful pregnancy, and there are treatments now to prevent and also treat, not to prevent, but to treat peripartum cardiomyopathy in the form of bromocriptine, but I haven't got enough time to go through that today. Any severe outflow tract disease is a red flag. That would be severe mitral stenosis or severe aortic stenosis, or severe coarctation of the aorta. Anyone with a dilated aorta, particularly if they have Marfan syndrome, these are all cardiovascular pregnancy red flags. So when someone has that in their history and they are pregnant, they need to be referred to a specialist center that not only can deal with cardiology, but also has a very strong cardio-obstetrics program. Just going to go through, let me see what this is. Yeah, I don't know if, have we got enough time for, do we have enough time for a couple more slides? Is that a yes? Let me see if there are any messages there. Okay, I think I'll continue just a couple of cases, maybe just to round off. So this is the importance of history in ECG. This is someone who had chest discomfort at rest, suggestive of an acute coronary syndrome. Initial resting ECG wasn't too abnormal, though if you look closely, you'll see there is sort of planar ST sagging or depression in the lateral leads. If you repeat the, whoops. My screen is frozen. Let's see if I can. Okay. Just it's loading up. Are there any questions that people have as we're approaching the end of the talk? Can't see any questions. Okay, so oops. So that was the initial ECG. No, I think this is the initial ECG. This is the initial ECG. That's the next one. You'll start seeing the evolution of ischemia with T-wave inversion, a little bit of ST elevation, deep T-wave inversion now anteriorly. And this is really just to give you a tip that when you're trying to assess patients with chest discomfort or suspected acute coronary syndrome, it's serial ECGs that you need, not just one, but serial ECGs, particularly if the first one is normal or only has a marginal abnormality. Obviously, if there's a gross abnormality that's suggestive of an acute coronary syndrome, then you've got the diagnosis. But the difficulty comes when the ECG is either normal or marginal or within normal limits. And the answer is just to repeat the ECG. And then you'll see that the this thing keeps on freezing. Okay, I think I'm going to, because of the time, I'm going to stop there. Are there any questions? Or any topics that people want to rediscuss? Any questions at all? It's a bit of a potpourri of topics, and the idea is really just to give you some practical top tips. The exam won't have too much specifically on red flag, but that you might get questions that ask you, sort of MCQ. What are the might give you a STEM styles. The STEM style question, which gives you a vignette, a clinical vignette, and then the question might describe something along the lines of, well, what red flag, what symptoms suggest that there is a cardiovascular red flag. I don't know, someone who has a 50-year-old gentleman who has hypertension, who has acute chest pain radiating to the back, would be a red flag for aortic dissection. Someone who has chest pain at rest with ST depression on the ECG, again, that's a red flag. Someone who's unexplained chest pain that's and associated with a syncope would be a red flag, and so on and so forth. These are the kind of things. It's a relatively subjective topic, I would say, but in practical terms, it's very important to pick out all those cardiovascular conditions which do have a acute mortality implication. And I've given you probably the majority of them today, but HCM, the audio was gone up from this point. So for hypertrophic cardiomyopathy, That's the, if you like, probably one of the most frequently encountered heart muscle disease that you'll see in clinical practice. There are obviously lots of others that are much more rare. The difficulty with hypertrophic cardiomyopathy is that it's there's a lot of overlap in terms of the echo and ECG findings with hypertension, because hypertension, systemic arterial hypertension, is very common. So the question becomes, how do you disentangle the two? And the answer really is to do with the history and some features on the echocardiogram. So with the history, if there's a family history of cardiomyopathy, obviously it's more likely that what you're looking at is someone who has also the same cardiomyopathy. Not 100%, but it's a pointer. If someone has a red flag symptom such as a syncope associated with left ventricular hypertrophy, then that's also a red flag. If someone has on their echo moderate or severe left ventricular hypertrophy, even if it's concentric, classically hypertrophic cardiomyopathy is dominated by the obstructive variant. In other words, where you have asymmetric septal hypertrophy of the left ventricular outflow tract. But there are lots of variants of hypertrophic cardiomyopathy which give you concentric left ventricular hypertrophy. So the fact that hypertrophy is concentric in itself isn't a hard and fast rule that excludes hypertrophic cardiomyopathy. So the context of the symptoms and the extent of hypertrophy are the key determinants here, whether you consider something to be a red flag. If you see someone in the clinic and they've got hypertension and they have an ECG showing left ventricular hypertrophy with a strain pattern, you do an echo and the echo shows mild concentric left ventricular hypertrophy, and there are no red flag symptoms, you don't need to do anything. However, if you have someone who has an unexplained syncope and they have, let's say, an abnormal ECG in the form of left ventricular strain pattern, and you do an echo and you have moderate concentric left ventricular hypertrophy, that is a red flag. Similarly, if you have someone who has a family history of unexplained or sudden arrhythmic cardiac death, and they don't have hypertension, and they have an abnormal ECG suggestive of left ventricular strain or concentric left ventricular hypertrophy, again, that will be a red flag. So the clinical context is very important. So I put that in there because hypertrophic cardiomyopathy questions often come up in clinical practice and also in the exam. Any other questions? Okay, I think I'm going to leave it there. If there are additional questions that come to mind, do link in with the facilitators, and we'll see you at the next webinar. Okay, goodbye.